Then I would like to introduce John Laffey. He's Professor of Anesthesia and Intensive Care Medicine at the University of Ireland in Galway. He will talk about the basics of invasive mechanical ventilation.
My name is Professor John Laffey. I'm delighted to be giving this talk today on the basics of mechanical ventilation. So in terms of learning objectives, what I'd like to try to cover is the basics of the ventilatory hardware, the circuit, the screen, and the components of the circuit. We want to talk a little bit about setting up the ventilator, what parameters you set and what parameters you measure, and then a little bit about the basic ventilator regimens, the different modes of ventilation that we use. So when we breathe spontaneously, we are using a low pressure system. We expand our rib cage, which leads to a volume change, which then creates a pressure difference, which leads to the gas flow from the upper areas down to the alveoli. In mechanical ventilation, this is generally reversed in that the mechanical ventilator generates a pressure difference. This then leads to the gas flow, which leads to the inflation and volume change in the lung. And the reason this is important is that it is inherently a higher pressure system when you are artificially ventilating the patient. So the pressures are higher in artificial mechanical ventilation with positive pressure than they will be in the spontaneous breathing. And a key goal is to reduce as much as possible the potential for pressure damage to the lung. So in terms of the ventilator, this is just a standard ventilator, and I'll show different pictures of ventilators in my talk, and it doesn't necessarily imply any endorsement of any ventilator. This is what you will be faced with when you want to connect a patient to the ventilator. So you have a ventilator. This is the central control area. This is the screen that you'll do your settings. These are knobs that you'll use to make those setting changes. And this then feeds to an inspired limb, which pushes gas through usually a humidifier to warm and moisten the gas. It then goes through the circuit and out and into the patient's lungs. In this case, there's a test lung here. On inspiration, the valves open and the gas is exhaled through the exhalation circuit. These are moisture traps to trap any water that rains out in the system. So all ventilators have this basic circle circuit design with nebulizers or humidifiers added to the circuit. So getting up a little closer to the ventilator, this is what a standard ventilator screen and box looks like. So most ventilators have a touch screen monitor. They'll have on-off buttons and alarm silence buttons. There may be some analyzer devices in the hardware part of the system. Then there's your expired and inspired limb. And most actions are controlled through this control knob, and then you touch directly on the screen for making changes. So in terms of the parameters you can set on the ventilator, there are multiple parameters. So you can choose the mode of ventilation, and we'll talk about that a little bit more later. The rate of respiratory, the respiratory rate, the size of the breath, the inspired oxygen, what's called pressure support in some modes, the amount of time in each breath that's spent in inspiration and expiration. This is the IE ratio. The pressure limit, which is a safety limit in the system to prevent very high pressures being delivered, and any positive end expiratory pressure you wish to set in the system. The parameters you will measure, many of them are the same as those you will set. So it confirms that what you set is what you have delivered. And then there are some additional parameters that are measured. So we will always measure tidal and minute volumes. We measure airway pressures. We'll measure the amount of oxygen actually delivered to the patient. And then most modern ventilators will have additional parameters they measure, such as flow volume loops or pressure volume loops. Again, looking closer at the screen of the ventilator, At the top, you will usually have something that tells you about the mode of ventilation that you're using. If your ventilator is enabled to ventilate children as well as adults, that will be there. There'll be an alarm silence function. Then there are the buttons that you set. So these will depend on the mode of ventilation, but they will always include oxygen, either pressure, inspiratory pressure, or tidal volume, PEEP. And then there are the waveforms. So these are pressure over time, flow over time, and then pressure volume loops. There will then be a section on the screen for the parameters you are measuring. And then there will usually be a number of extra buttons either on the side or the bottom for specific interventions you might want to do, like a breath hold, for example. So I won't dwell much on this, but there are multiple indications for initiation of mechanical ventilation. Of most relevance to COVID-19 are acute hypoxemic respiratory failure, hypercapnic respiratory failure, and respiratory muscle fatigue. Some patients may be ventilated for reduced loss of consciousness, for example, in hypercapnic respiratory failure. In terms of the initial ventilator settings, the first thing you usually set is the breath size. And we look to match what is the normal sized breath. So a normal physiologic breath is 5 to 8 mils per kilo. So we would normally set the ventilator to start somewhere in that range. Now we talk about predicted body weight, not actual body weight, when measuring setting tidal volume. And this is because your lungs, unfortunately, do not get bigger when you gain weight. So they are much more closely related to your gender and to your height. So there are simple formulas that allow you to calculate this. And in fact, many modern ventilators will do this for you automatically when you enter the patient's details. In terms of respiratory rate, we tend to go a little higher usually than the normal spontaneous breathing rate. So 14 to 18 breaths per minute is a reasonable place to start as a setting. So I want to talk a little bit now about modes of ventilation. And there are two basic modes that need to be understood, and that's volume control or pressure control. So control refers to what the primary thing is that you set on the ventilator. So in a volume controlled mode, you are setting the size of the breath, so the tidal volume. Given this, that's the independent setting that you set, you then need to monitor very carefully the airway pressures, because this will vary depending on the condition of the lung. For example, a stiff lung or a lung with high airways resistance. Pressure-controlled ventilation modes, in these modes, you set the pressure that you want the ventilator to deliver the lung, the maximal pressure they will inflate to. And so then in this mode, you need to watch the tidal volume very carefully, because this will vary depending on, again, the respiratory mechanics. For example, if the lung stiffens, the tidal volume will drop. So when we look at what's happening in terms of the waveforms you will see on the ventilator screen, what you are setting in volume control is the tidal volume. So you will use the button for tidal volume. You'll set this, in this case, at 500. And then you will have almost always a constant flow inspiration with volume control. That's the default setting. So you will have a standard stable flow, and then the airway pressure will vary depending on how stiff the lung is and the resistance in the major airways. So when you set in volume control, what you really want to watch closely are the pressures. So this is the same set of waveforms, but now in a pressure controlled mode. So with this mode, you're setting the pressure. And so you're setting the pressure here, say at 15 centimeters of water. You see the flow pattern is different because it goes immediately to that pressure. And then this is a descending pattern of flow. What you need to watch very carefully is both the flow and the tidal volume, because these will both vary depending on the lung characteristics. So just to try to kind of reinforce this point, because it really is critical to your monitoring strategy. When you are in volume control, what you set is the tidal volume. Unless you change the flow characteristics, this will be a standard flow pattern, a square wave flow pattern. And so what will vary, or the dependent variable, is the airway pressure. So when you are in a volume control mode, what you really got to watch are the airway pressures. So in this case, this is the peak airway pressure and this is the plateau pressure. When you're in a pressure control mode, what you are setting now is the airway pressure. So flow and tidal volume will both vary depending on the characteristics of the lung. So what you've got to watch in these is the flow, which can be very high at the beginning of inspiration, and you've got to watch the volume, which can change unexpectedly with changes in lung compliance or resistance. You can change the inspiratory flow pattern on the ventilator, although this is quite an advanced approach. What you will see most commonly are the constant flow pattern, which are the square wave pattern, which you will see as standard in volume control modes, or a descending flow pattern, which is what you tend to see in the pressure control modes, where you can alter this to ascending pressure flow patterns or sine flow patterns. Frequently in volume control ventilation, we will set an inspiratory pause at the end of the inflation phase. So this is what the flow pattern would look like if there is no pause. So you have a peak inspiratory pressure and then the ventilator opens or cycles to expiration. If we add a pause here, there is no flow during this period, and therefore the pressure that we see here is thought to reflect the pressure further down the lung, ideally the alveolar pressure. So this is the plateau pressure, and this is used as an index in terms of the safety of the ventilation. So we try very much to keep this pressure as low as possible and certainly below 30 centimeters of water. The inspiratory hold may also have the effect of improving the distribution of gas or air within the lung because it allows time for mixing at the lower alveolar segment areas. Another parameter you will set on the ventilator is PEEP. So this is positive end expiratory pressure. So this is a constant positive pressure that's kept in the circuit even when the machine has opened to expiration. And the aim of this is to improve opening of lung units which are at risk of collapse or have collapsed already. So very often in acute lung injury, such as in the COVID lung, you'll have areas of alveoli that are quite collapsed and that then open irregularly in inspiration. And this can cause damage and harm to the lung. So PEEP can open that and hold it open throughout the inspired and expired cycle. So one of the areas of complexity that frequently causes confusion around ventilation is the naming of different ventilatory modes. So when we talk about mode, we're talking about the inspiratory support method. We've talked a little bit already about the control variable, which is either pressure control or volume control. But there's also, in the different modes, there are different ways in which the breaths are given. So a mandatory breath is a breath that the machine delivers to the patient, irrespective of the patient's effort. Whereas a spontaneous breath is one that the patient initiates. And this is either supported by the ventilator or it can be completely unassisted, depending on the mode of ventilation you choose. So when we are naming the different modes, what you will see is the control variable comes first, either pressure control or volume control, so that's PC or VC, and then the breath sequence or breath strategy. So that could be all mandatory breaths, such as a continuous mandatory mode, an intermittent mandatory breaths, or spontaneous breathing. So the common modes you will see used in the intensive care unit will be modes like continuous mandatory ventilation, say if a patient is paralyzed, intermittent mandatory ventilation, or continuous spontaneous ventilation. There is limited evidence that modes affect clinical outcomes. So you will see in the different ventilators, you may see many different modes. And this is often a major selling point around ventilators. And clinicians may often have a particular mode they like to use more than another mode, but there really is very little evidence to support the use of one mode over another mode. And certainly when dealing with COVID patients, particularly when you are maybe less familiar with the ventilators, I would suggest that you keep the use of modes to a very limited number of modes, and we'll discuss these in the coming slides. So controlled mode continuous mandatory ventilation is the simplest ventilatory mode. You will not see this used much in the intensive care unit. This is something more used in the operating room where a patient is deeply anesthetized and paralyzed. But basically the ventilator is doing all of the work. So there's a preset tidal volume, preset respiratory rate, and that is delivered by the ventilator. The patient does not breathe spontaneously. There is no facility in this mode for the patient to breathe. So unless the patient is deeply anesthetized, this can be quite an uncomfortable mode. And so you will not, this is not a familiar mode, but it's useful to understand it in terms of, you may see it in patients who are paralyzed. Assist control mode ventilation is a common, relatively common mode of ventilation of very sick ARDS or COVID-19 patients in the intensive care unit. So the ventilator provides the patient with a preset volume and a preset rate. This can be either volume control or pressure control, and a mandatory or controlled respiratory rate is selected. So we might set a rate of 15 breaths per minute, for example, in a volume or a pressure control mode. The patient can breathe at a higher rate than this and can initiate the breath by triggering the ventilator. And the ventilator will sense the patient's effort either by a flow mechanism or a pressure mechanism using sensors, and it will know that the patient is trying to take a breath and will then assist that breath by delivering the preset volume to that patient. So the total respiratory rate is determined by the number of spontaneous breaths initiated by the patient plus the number of breaths set on the ventilator. So we say this is often used as the initial mode of ventilation for deeply sedated or very sick patients in the intensive care unit, such as an early phase ARDS, where the patient is really too ill or too unstable to perform any component of the work of breathing. And indeed, it is the mode of ventilation used in the ARDS-NET tidal volume studies. So it is actually the only mode of ventilation for which there is any evidence for its use in ARDS. Synchronized intermittent mandatory ventilation, or SIMV, again is a relatively common mode of ventilation you may see used in the intensive care unit that you work in. The ventilator will provide the patient with a preset number of breaths per minute at a set tidal volume. So we may set like 15 breaths per minute at a tidal volume of 400 mils. The spontaneous breaths are allowed between the mandatory breaths, so it is an intermittent mandatory mode. The spontaneous breaths, however, though, are unassisted by the ventilator. So the circuit will simply open and allow the patient to take the breath. So tidal volume during these spontaneous breaths can be highly variable, as it is entirely effort dependent by the patient. However, you can add a pressure support, which we will discuss later, to this to assist these breaths. But the important point is that the mode of itself does not assist the breaths. The ventilator breaths are synchronized with the patient's spontaneous effort. So this should help to reduce ventilator dysynchrony. In terms of pressure modes, there are multiple different pressure modes you may see used in the intensive care unit. So we've talked a little bit about already about pressure control ventilation. There is also pressure support ventilation, or PSV, continuous positive airway pressure, or CPAP, and BiPAP, or bi-level positive airway pressure ventilation. With each of these modes, you may also see positive end expiratory pressure, or PEEP. So BiPAP then, in BiPAP, the ventilator delivers a preset higher inspiratory and lower expiratory airway pressure. So the ventilator cycles between two different levels of positive pressure. This cycling is usually time cycled based on the IE, or inspired to expired ratio, that you set on the ventilator. So the system allows the clinician to select two levels of positive pressure support. The inspiratory pressure support level is called an IPAP, and the expiratory pressure support, which is called an EPAP. You may also see this called PEEP or CPAP as well. BiPAP may also be delivered non-invasively, and this is actually quite a common non-invasive mode of ventilation. So you can use your ventilator, but instead of an endotracheal tube in the lung, you have a face mask or nasal mask strapped to the patient's face, but then the patient is able to initiate these breaths at high and low pressures. The pressure support ventilation then is a type of assisted spontaneous ventilation. So this is an entirely spontaneous mode of ventilation. The patient initiates every breath and regulates their respiratory rate themselves. So they trigger the ventilator either using a pressure trigger or a volume trigger. So the ventilator can sense patient effort, and it then delivers a constant inspiratory pressure to the circuit to aid the patient's inspiratory effort. Pressure support ventilation is usually started to begin the process of weaning or discontinuing ventilation. So the positive pressure delivered during pressure support helps to overcome airway resistance and resistance within the ventilatory circuits, and to thereby reduce the work of breathing. You set the pressure level of pressure support based on the amount of effort that you want the patient to make in order to avoid the patient prematurely fatiguing due to the workload on their respiratory muscles. So what we would normally do is set a pressure support quite similar to the level of pressure that the ventilator was delivering in a more controlled mode of ventilation, and then we can gradually reduce that pressure support amount over time as the patient gradually trains their muscles and regains their muscle power. It is important in this mode to monitor tidal volume and respiratory rate very closely, because changes again in the patient's lung mechanics, both compliance and resistance, may lead to very significant changes in both respiratory rate and tidal volume. And you can have a situation where an improving patient may start to take very large tidal volumes due to the pressure support that you have dialed in to the system, and can actually cause injury and damage to their lungs. Importantly, you will often see pressure support ventilation used with other modes of ventilation. So to assist, particularly in SIMV, when the patient initiates their own breath. So you will see pressure support ventilation combined with other modes. So CPAP is another mode of ventilation that you will see frequently in the intensive care unit, particularly in weaning patients. So this is a single positive airway inspiratory pressure. It's constantly there throughout the cycle, and its primary aim again is to reduce work of breathing and reduce the potential for lung collapse. CPAP will be more often delivered through a face mask than via an endotracheal tube. So it's very much, or more commonly, used as a non-invasive ventilatory approach. With that, I'm happy, I will stop now, and I'm very happy to take questions. And I'm delighted to welcome you to intensive care medicine, and hope you won't find the ventilator too challenging. Thank you.
Thank you, Professor Laffey. I thought this was a very clear explanation of the basics of mechanical ventilation, which does not elicit a lot of questions from myself. Other than that, I can imagine that our colleagues may ask themselves, okay, in respect to the control modes, why are there so many control modes, and is one mode better than the other? How should I choose among them?
So
Yeah.
certainly when you're not familiar with the ventilator, I would keep mode use very simple. So volume control should be your go-to mode. And what we tend to use most commonly is assist control in early ARDS. So we would dial a protective tidal volume, set our PEEP, and then allow the patient to initiate a small amount of their own breathing. So we tend to use volume assist control as our main mode in early ARDS, and we then, as the patient improves, we move relatively early to the use of pressure support. There are lots of other modes, but I think if you familiarize yourself with those two first, that will make it a lot easier for you to manage these patients.
So, and as you say, with the use of the volume control, you should set the limits for the pressure, so to avoid high pressure ventilation and barotrauma, right?
Yes.
Yeah, another
Sorry.
question I would have is, okay, when is the patient ready to switch from control to support mode? What are the parameters that you watch in order to decide this?
So I would look at the amount of support the ventilator is giving to the patient. And I would also look at the general condition of the patient. So if the patient is improving clinically and is reducing down in the amount of oxygen they require, certainly below 60%, inspired oxygen concentration, if they are hemodynamically reasonably stable, then I would start weaning. So weaning can start quite early in these patients and have the patient start to do some work once they move beyond that initial very critical phase where they may be difficult to oxygenate.
Okay. Okay, thanks a lot for your clear explanations. Thanks for your talk. Goodbye.
Thank you very much. Thanks, Professor Yerkelmans.